Okay, this is Unit 4 in Micro, and this is, we're going to start talking about different cultures and different body sites and what kind of organisms infect those body sites. And we're going to start out with the spinal fluid and other body fluids, and the information comes from Chapter 35, which starts on page 854 in your book. Okay, the spinal fluid, is in the nervous system. The nervous system contains the brain, the spinal cord, and the meninges, which are the membranes that cover the brain and the spinal cord. Infections can be viruses, bacteria, fungi, and even parasites. More commonly, it's viruses or bacteria. Normal values you need to know. Spinal fluid looks like water. It's very clear and colorless in a normal patient. The total protein is 15 to 50 in adults and 15 to 170 in kids. The glucose is 40 to 80 in adults, and children is 30 to 130. The leukocytes. With white cells, adults usually have lymphs, and there's less than 5 to 10 is normal, so 0 to 10 is normal, and that's per milliliter. And in children, they usually have monos and neutrophils normally, and it's okay to see 0 to 30 per milliliter. The LDH, if it's ever high, that could mean a bacterial infection. The total volume in the entire body is between 90 to 150, and it's constantly being formed. 400 to 600 is formed in one day. There is no normal flora in spinal fluid. Spinal fluid is a sterile body site, and there should be no organisms growing in a spinal fluid culture. Okay, the way that this is collected is by the physician. It should be collected before any antibiotics are started, so it's usually done right away, and anytime we have a spinal fluid, the test is performed stat, no matter what the test is, no matter what department. It's done on the lumbar spine, and the fluid is in the subarachnoid space, which is a space between two of the membranes where the spinal fluid is located. So the doctor disinfects the site with 70% alcohol and 2% iodine, and they insert a needle and they collect the spinal fluid. Now these tubes in the picture look empty to me, but they usually send them in 4 or more tubes with just a little bit in them, maybe like 1 ml down here at the bottom, and it looks just like water. Tube 1 is the fluid that's drawn off first, and this is supposed to be given to chemistry for total protein and glucose and maybe LDH or other chemistry tests. Tube 2 is supposed to be for micro. This is gram stain and culture. In both of these tubes, you centrifuge the specimen down and you perform the test in chemistry on the supernatant. And in micro, you perform the test on the sediment because you're going to centrifuge the bacteria, if there's any in there, to the bottom. Tube 3 is for hematology. You do not centrifuge that. It is mixed and you do a cell count on it. And tube 4 is for serology testing. And serology, it depends on what the doctor suspects is wrong with the patient, but they may order things like a VDRL for syphilis, West Nile virus, a bacterial antigen test for meningitis, just different kinds of serology tests. The specimen should be transported to the lab within 15 minutes, and specimens that are not processed immediately should be placed in the 37-degree incubator or at room temperature. Now this is referring to the microtube, because if there's any bacteria in tube 2, then we would want to keep it at 37 to keep the bacteria alive or at room temperature. The other departments have other requirements. Okay, it needs to be processed stat. Neutrophils will lyse if the spinal fluid is hypotonic, and the cells will start to degenerate. 50% will degenerate at room temperature. Some of the organisms may not live if it comes to room temperature or even colder. So like Neisseria gonorrhea or Haemophilus influenza, those are very fragile organisms and they need extra care to live, like CO2 and warmth, or they're going to die. Okay, the cytospin. This is a special centrifuge, and this is a picture of one kind. It's a special centrifuge for fluids, and it has these special little cartridges, which is what these are. They're little plastic cartridges, and you put the microscope slide in that, and then there's a place for you to put drops of the fluid, and you balance it just the same. You centrifuge it for 5 minutes at 1500 G's, and it will make the sediment for you on the slide. Now this is usually used only in for a diff in hematology, or the gram stain in the culture, or India ink, because it's going to concentrate the fluid. Sediment has got to be used for gram stain in culture, India ink, which is for Cryptococcus. And there's also a direct antigen test, which is a agglutination test that's used to detect common organisms that cause meningitis. So we have an example of one of these kits in our lab, and the organisms that that particular kit tests for are Neisseria meningitidis, because that's a common pathogen for meningitis in children. Strep pneumo, Haemophilus influenza, Staph aureus, E. coli, group B because of babies, but it's a quick agglutination test that's done on spinal fluid to detect the common organisms that cause meningitis. Okay, the culture we set up on routine media, and the routine media for most places is a blood agar plate, a chocolate, and a McConkey, and some people use different kinds of broth, but a Thio or a chopped meat broth or tryptosoy broth is also used. And we always do a gram stain on spinal fluid so we can tell the doctor immediately if there's organisms there. So we inoculate the sediment, so you have to, like you do in your analysis when you take the supernatant off, you have to separate it and then use the sediment to put on the slide and to put on the plates and streak it. You incubate the plates at 37, and the chocolate has to be in the CO2 because the chocolate is for the fastidious organisms, and they need, or most of those need, CO2 to grow. All the organisms are worked up. That means that you identify them because this is a sterile body fluid. Anything that grows you need to identify because that could be the pathogen. Okay, the terms, these are the three membranes or the meninges. The pia mater, and you can't see those words very well, but this is the pia mater, The arachnoid is right here, and then the dura mater, if you can follow it, is right here, and in the subarachnoid space is here, and this is where the spinal fluid is. You don't need to know this diagram, I just put it on there so you could see where the parts are. The spinal fluid bathes the brain and spinal cord. It's kind of like helps it cushion, but not only that, it's constantly bringing nutrients and things to the brain. Meningitis is inflammation of the meninges. Acute meningitis is one that starts and within several hours the patient is very, very sick. Subacute, the onset is several days or hours, and with this one it gradually comes on them, so they may just start out with a slight headache and it just gradually gets worse. Chronic, the symptoms can last for 4 weeks, and it takes them even longer than subacute for their symptoms to be severe. Encephalitis is inflammation of the brain. Usually the organism is a virus that causes encephalitis. Meningoencephalitis is the inflammation of the brain and the meninges. Okay, so how do these organisms get in there? There's 4 ways that the organisms travel. The first one is hematogenous, whatever, from the bloodstream. So in this case, the patient is septic, and there's organisms in their bloodstream, and it crosses the blood-brain barrier and gets into the spinal fluid. A contiguous spread is from adjacent areas, mainly the sinuses. So a severe sinus infection does have the potential to cause meningitis, but it's not common. Trauma to the patient that affects the spinal cord or the brain, and also surgery or shunts that have to be done on that system. Okay, so these are the symptoms. They're flu-like, headache, fever, nausea, vomiting, a stiff neck, which is nuchal rigidity, and mental status change. Young children and babies, they don't eat. A lot of times they're lethargic. They don't have much life to them. They're just laying around not doing anything. Okay. The organisms. These are usually based on age. Certain organisms are common in babies, and then certain organisms are common in adults. In neonates, which is considered less than 1 month, the organisms here almost always come from the mother's vaginal tract during delivery. So I hope you know E. coli and group B and Listeria right off the bat, because we talked about that in the first micro, but also Klebsiella and Enterobacter are capable of doing that too. Infants 1 to 23 months, so this is 1 to 2, 1 year to 2 years. The most common are group B, strep pneumo, E. coli, Haemophilus influenza, and Neisseria meningitidis. Young children, Neisseria meningitidis. Haemophilus influenza serotype B used to be the most common cause of meningitis in children, but since the Hib vaccine has been given out, that has declined, and I'm not sure if meningitis or influenza is the #1 one now, but the infections from serotype B have greatly decreased from the administration of that vaccine to kids. Other ones, older children, adolescents, and adults, strep pneumo. Elderly, gram-negative rods, mostly E. coli and strep pneumo. And immunocompromised patients, Mycobacterium or Cryptococcus. And for all of these cultures, we're going to talk about the most common pathogens. But you know, especially depending on the patient's immune status, almost any organism could cause meningitis or could be get into the spinal fluid. The less encountered ones are treponema, that's syphilis, Borrelia, Naegleria, enterovirus, herpes, mumps, candida, which is a yeast, Staph aureus, and different types of fungal organisms like coccidioides or histoplasma. Those can get into the spinal fluid. Okay, on page 3 in your lecture notes, there's a list of some organisms, and I want you to look up how these are identified. So you're going to have to go back to your first microbe notes, and what I want you to do is tell me the main test results for each of these that are listed on that page. So I've done the first one for you, Haemophilus influenza. If you've got Haemophilus influenza, what tests are going to be done and what is their reaction? So when you're looking at the plates, it's only going to grow on chocolate. It shouldn't be on blood and McConkey. When you do a gram stain, you're going to see gram-negative Coccobacilli. It's oxidase positive, catalase positive, and then the next step is you do the Haemophilus identification plate. And influenza requires X and V. There will be growth on section 3 in the quad plate, and there will be no hemolysis. I want you to look these up because you're getting ready to go to clinical and you're going to start reading cultures, and you need to tie this with the first microbe. You need to tie these reactions, and I want you to study these reactions that you look up. And if you have a question about any of them, especially maybe like Nocardia. We didn't talk a whole bunch about Nocardia, but I want you to know what I've told you in your notes, and that's all you need to know. We didn't have to go into identification too much with that one. Okay, so if there's any organism seen on the gram stain or grows in the culture, it needs to be reported to the physician or the nurse taking care of the patient immediately. This is a life-threatening infection, and it needs to be brought to their attention as soon as possible, and as soon as we know what type of organism it is, they can get on the right type of antibiotic. Okay, this is not in your notes, but you need to know this. There's a good chart on page 865 that has tuberculosis and fungus and syphilis and even parasite results, just like I've done the bacteria and the viral. But this is what you need to know between bacterial and viral meningitis. Neutrophils fight off bacteria, lymphocytes fight off viruses. So in the spinal fluid, DIF, you'll see mainly neutrophils for bacteria. The glucose in chemistry is decreased because the bacteria are going to consume the glucose in the spinal fluid. So it's going to be decreased, but viruses don't, so this is going to be normal for those. Bacteria, there's going to be increased protein, and in viruses, there's normal protein. Okay, other body fluids. This is a few terms just to make sure that you know what I'm talking about, what these words mean. So amniocentesis is the procedure in which amniotic fluid is drawn off. So the doctor may say, we're going to do an amniocentesis on the patient, and what that means is they're going to draw some amniotic fluid. Arthrocentesis is joint fluid. This is the process of collecting it. Pericardiocentesis is heart fluid. Paracentesis is abdominal fluid, and thoracentesis is the lung fluid. So an arthrocentesis will give you joint fluid, and it's also called synovial. Pericardial fluid is also called heart fluid. Peritoneal fluid is in the abdominal cavity, and it has 3 different names: peritoneal fluid, abdominal fluid, or ascites fluid. And also pleural fluid is from the lungs, and it can be called pleural fluid, lung fluid, or thoracentesis fluid. These should be transmitted within 15 minutes and stored at room temperature. They're collected in they're not collected in those same kinds of tubes that you saw with the spinal fluids. They're collected in different things. Most of the time they come in syringes or even real large containers or plastic bags, sterile bags. But they can be in anaerobe tubes, other kinds of screw top tubes, and even blood collection tubes. When I was at Loris, we never liked to do that, but after they had already put the fluid in the blood collection tubes, the blood culture bottles, we had to keep it in there. Okay. With the blood cultures, body fluid cultures, these are the routine plates that need to be set up, and this is the same thing as spinal fluid. Sometimes the doctor will order a Mycobacterium tuberculosis culture. This is a blood culture bottle, and it looks like they're drawing it from some kind of line, but again, we don't like to collect it that way. The causative agents in amniotic fluid. This is the fluid that cushions the baby. Listeria, lactobacillus, anaerobes, or Gardnerella. Pericarditis, that's around the heart. Staph aureus, Bacteroides, Clostridium, Strep pneumo, and Strep pyogenes. Peritoneal or dialysis fluid, Staph epi, Staph aureus, and gram-negative rods. The pleural fluid, Staph aureus, Strep pneumo, Pseudomonas, Haemophilus influenza, and Enterobacter. Knee fluid, this is joint or synovial fluid, Staph, Pseudomonas, and anaerobes, and sometimes Neisseria gonorrhea. If patients have had Neisseria gonorrhea and they don't get treatment, it can eventually get into their joints and cause a type of arthritis. Okay, so now for blood cultures. These are some terms you need to know about infections in the blood. Bacteremia just means that there's bacteria in the blood. The presence of bacteria. Pseudobacteremia is a false positive blood culture, and the bacteria actually comes from the skin of the patient when the phlebotomist is drawing the blood culture bottle. Septicemia is when there's bacteremia with signs and symptoms. So these patients have bacteremia and they have symptoms: fever, shaking, chills, hypothermia, nausea, and vomiting. Septic shock is when the patients have a very rapid drop in blood pressure, and this has a high risk of death, and this usually goes with some of the gram-negative rods, especially E. coli. Primary bacteremia is from a vascular source. This is like a heart valve or a catheter, and if the catheter or the heart valve becomes contaminated, the bacteria is being put right into the blood vessel. Secondary comes from an extravascular source, so this would be usually an infection somewhere else, like an abscess or pyelonephritis. When patients have pyelonephritis, the kidney itself is infected, and in the kidney, that's where our blood goes to be filtered. So the bacteria can get in the bloodstream from going through the kidney where that's infected already. Okay, community acquired means that the patients got it at home. Hospital acquired or nosocomial means that they developed it after they had been admitted to the hospital. Most hospitals say 72 hours after being admitted. If you develop something new, then it's hospital acquired, even though you may not have actually got it from the hospital. Transient bacteremia is one that when the bacteria comes into the bloodstream for only a short amount of time. And a good example of that is after you've had a tooth pulled or after colonoscopy. The bacteria can get into the bloodstream and you may not even ever know it. The patient can recover quickly. The body will take care of it. Intermittent is released intermittently. That means that it's released and then it may be a while and some more bacteria is released, and then it may be a while and some more are released. And this is usually from abscesses or other types of infections. Continuous is when the bacteria are in an intravascular place. Like endocarditis. In endocarditis, the heart is infected and the bacteria is going directly into the blood. Okay, risk factors, usually the very young and the very old are the ones that get septicemia, although it can be at any age. Immunocompromised patients are usually at risk. Patients who have undergone invasive procedures like surgery or colonoscopy or what have you. And also drug therapy. If they've been on steroids or chemo, it will knock their immune system down so they're not able to fight it. And also broad spectrum antibiotics. Broad spectrum antibiotics are usually not as strong as narrow spectrum ones. So what happens is the broad spectrum antibiotics will kill a lot of the normal flora, and then very resistant organisms are allowed to proliferate and grow and cause a more dangerous infection. Okay, blood culture contamination. Like I said before, whenever the phlebotomist is drawing a blood culture, in a blood culture draw, you are supposed to use iodine. You put the iodine on the site, you let it sit 1 full minute to kill the bacteria on the skin, and then you stick the patient. You don't retouch it, you don't put alcohol on it again, nothing. Well, if this is not done properly, like it's supposed to be done, then normal flora from the skin gets into the blood culture bottle. And it will look like the patient has sepsis, and they don't. So 1 to 3% of the pseudobacteremia is due to Micrococcus coag-negative staph, and Micrococcus is a coag-negative staph, but also like Staph epidermidis and Staph saprophyticus. Diphtheroids and Bacillus are both gram-positive rods that are normal flora. alpha strep or gram-positive cocci, different types of strep, not like strep pneumo or enterococcus. Propionibacterium is gram-positive rods. These are all found on our skin. If they get into the bottle, they will cause the blood culture bottle to be falsely positive. And first of all, the doctor will think that the patient has sepsis, and he will treat the patient. It may mean for them to stay in the hospital longer. It makes the microtech work on this. When the blood culture bottle comes up positive, they've got to take that bottle and do a gram stain, put it on plates, and then the next day they've got to identify the bacteria growing, and then we also set up antibiotics. So it wastes time, it wastes reagent, and it costs a lot. So a lot of things happen unnecessarily if there's a blood culture contamination. Okay, so how do you collect it? You find the vein and you clean the site with alcohol, and then you use povidone iodine and you make concentric circles. So let's say that this is where I'm going to stick. I would start in the center and go around and round with the iodine ampule outward, and then you allow it to sit for 1 full minute, 1 whole minute. If the patient is allergic to iodine, and there's some people that are, and it can be a severe allergy, so you always need to ask. If you can't use iodine, you use a second alcohol cleaning and you allow it to air dry. You don't wipe it clean. So then it's collected with a butterfly or syringe. You clean the iodine off with alcohol, because if you don't clean it off their arm, it just leaves a mess. And you invert the bottles to mix. Let me show you this blood culture bottle. This is a type of blood culture bottle, and this has an adapter on it. And this looks like it's being drawn from a Portacath line or something from the patient. But if you were drawing this yourself, you can attach a butterfly to the top of that up here, or put a Vacutainer needle into that, and then you just stick the blood culture bottle on it. Okay, less than 10 years old. These blood culture bottles hold a lot of blood, and if the patient is small, like little kids, you don't want to draw too much blood from them to risk them being anemic. So you draw 1 ml for each year of life. So if the patient's 2, you draw 2 mLs. If the patient's 4, you draw 4 mLs. And there are pediatric bottles that are used, which only require a small amount to be put in them. If you're older than 10, 20 mLs is fine to draw off of them. The blood to broth ratio needs to be between 1 to 5, 1 part blood, 5 parts broth, all the way to 1 to 10. In adults, the aerobic and anaerobic set are collected. Usually 3 sets of these are collected. So if the doctor orders 3 sets, you're going to have 3 aerobics and 3 anaerobics to draw. So at 1 stick, you're going to collect an aerobic and an anaerobic bottle. And then if he's ordered 3 sets, you have to wait 5 to 10 minutes, and then you stick the patient again for their second set. And then you're supposed to stick in a different site. This is the best way to pick up the bacteria. So if you stuck in their right arm, you're supposed to try their left arm or their hand. And then if a third set is ordered, you should wait 5 to 10 minutes again and then collect it from a different site. So you're going to have 6 bottles. And the best time to collect is just before a fever spikes, and you know that's probably hard to predict, but that is the best time. That's when the bacteria is there and your body is um, hasn't started to react to try to get rid of it on its own. Okay, the blood culture broth. The types of broth are usually soybean casein digest, tryptase soy broth, or brain heart infusion. Some of them you can put a penicillinase or antibiotic removal device. If the patient is already started antibiotics, then these can be added to the blood culture broth to prevent the antibiotic from killing the organism, so it'll grow and they can tell what's wrong with the patient. The best thing to do is to get the blood culture bottles drawn before the patient starts antibiotics. And there are some blood culture bottles that already have these in them already, so it's not added. It's in all the samples. The anticoagulant is sodium polyethyl sulfonate, which is SPS. This is the same anticoagulant as is in the yellow top tube. It prevents clotting, it inhibits phagocytosis, it activates complement because that will kill the bacteria. It neutralizes some antimicrobials, some antibiotics, but it can inhibit gonorrhea, meningitis, and Gardnerella vaginalis. Citrate, heparin, oxalate, and EDTA tubes cannot be used. I have seen some phlebotomists draw a patient specimen for CBC or chemistry or whatever, and they were wanting to put some of the blood from the EDTA sample into the blood culture bottle, and that is not acceptable. The patient, this particular time, the phlebotomist was trying to get out of going to stick the patient again for the blood cultures because she had already stuck them for a CBC or whatever it was, and she didn't want to go and stick them again. Well, first of all, she did not use iodine when she collected the sample the first time if the blood cultures had not been ordered. So they probably would have been contaminated. But also, these other anticoagulants can inhibit the organisms from growing, so that could have killed them. Okay, the blood culture bottles that are biphasic. You see this word, biphasic. This means that there's 2 phases to it, and it has a broth and a slide to it. And this SeptiCheck is the brand name of these. But here's the broth, and here's this thing up here that we call a paddle. And the patient's blood is put down here in the broth, and you incubate it. And then the next day, you tip this bottle so that some of the broth will go on this paddle. And on this paddle up here is chocolate agar. So you tip it, put some of the broth on it, and you re-incubate, and then you wait to see if something grows. If it doesn't, you tip it again. And I think they keep these at least 5 days, just like a regular blood culture bottle. There's also this thing called blind subcultures, and that's what this is. You're putting the blood culture broth on the agar to see if anything grows. If bacteria was going to grow, it would be cloudy here. But if you do a blind subculture, there may be bacteria here and it's not cloudy yet because there's not enough to make it cloudy. And also a blind smear. And this is when we do a gram stain from a blood culture bottle. And these can be done not only from these biphasic bottles, but from the regular blood culture bottles if needed. Okay, these are the blood culture instruments. The BACTEC system, this uses automated radiometric growth in it, and the bottles have labeled, and you know what that means. It has it's labeled with fluorescence or a gas or something radiometric to it. When the bacteria uses the CO2 is released and it's measured. And when the system detects that there's an increase in CO2 in the bottle, then an alarm will go off telling you that a bottle is positive. The BACTEC 9000 uses fluorescence. It has a gas permeable sensor in it. CO2 is produced by the organism, and the increase in hydrogen in the sensor causes the fluorescence to happen. The ESP, this name has been replaced by Versatrek. Versatrek is the new ESP, and this monitors the production of gas because almost all the organisms that cause meningitis produces gas that can be detected. This is the BACT alert, or an example of one BACT alert, and this is a large one, but you can get one that is smaller than this. But these are where the bottles are, and you see she's pulling out the drawer on the one beside it. But this is the computer system here, and the bottles are in these drawers. And they're inserted in there, they're incubated at 37, and they're constantly being monitored. If one comes up positive, then the system will go off so you know. The BACT alert, the organisms produce CO2, and the pH change will turn the sensor a different color. And with these bottles, the sensor is on the bottom of the bottle, and they'll turn a light salmon looking color if they're positive. And then the instrument will read the bottom of the bottle, and it will alert you that one's positive. And they're also labeled like different rows and columns, so you know which one is positive. Okay, special considerations. There is a procedure called lysis centrifugation, in which the cells, red cells and white cells, are lysed, and then you centrifuge the blood in the broth, and you culture the sediment. This is used for fungi and mycobacterium. Francisella has to have cysteine and dextrose. It can't survive in the regular blood culture bottles. Brucella, it takes a long time for Brucella to grow. So in order to pick it up as quick as you can, it's better to use the biphasic blood culture bottles so that it'll come up, you can see it growing faster. Nutritionally deficient strep. When you have this, you'll usually see gram-positive cocci on the gram stain, and you put it on the plate, but nothing will grow on the plate. So if that happens, you suspect this type of strep. And the only way to get it to grow is to sub the blood culture broth onto a plate that has staph growing on it, and then the staph will give it the nutrients it needs to grow. So in this case, the broth can grow the organism, when it comes up positive, you do the gram stain and you see gram-positive cocci, and then you put the broth on McConkey, chocolate, and blood, but nothing grows. Okay, the cultures, they're usually incubated 5 to 7 days, at least 5. In the broth, you can look at it for turbidity. It'll be cloudy if there's organisms in there. Hemolysis, gas, and actual colonies starting to form. The bottle becomes positive. You do a gram stain stat, and it's reported, and you have to document that you reported it. And then you culture it to the agar plates. The incubation time, routine blood cultures are 5 to 7 days, but for fungi, 14 days, because you know those grow slower now. Brucella, it takes at least 21. So some places will keep it up to 28, and Leptospira 28. If the broth is positive but you don't see anything on the gram stain, then you go ahead and put it on the agar plates anyway. And I've seen this happen a few times where the broth would be positive, we do the gram stain, and we can't find an organism on the slide anywhere. So we would culture it to the plates and then something would grow. And I guess that it was just the organism was so few we couldn't find them, but it grew on the plate, so we were able to identify it. The most common pathogens. On page 7, there's a list of gram positives and gram negatives, and I picked out of those the ones that are most commonly seen in blood cultures. And these are them: Staph aureus, including MRSA, Enterococcus, Staph epi, E. coli, and Strep pneumoniae. And Staph epi is seen a lot in blood culture bottles, and it's hard to determine if it's the true pathogen or not. So sometimes we just work it up and it's for the doctor to decide, because that is one of the contaminants too. The gram-positive ones, Staph saprophyticus, group A and B, Viridans, strep, Candida, and Listeria. Gram-negatives are Haemophilus influenza, Pseudomonas, Klebsiella, Proteus, Neisseria gonorrhea, Neisseria meningitidis, Acinetobacter, Bacteroides, Enterobacter, and Serratia. And let me tell you this, when I was at the hospital, you'll see that when you're there, and if you're in micro from day to day, there's many times that you'll have a positive blood culture and the patient will also have a urine culture and they grow the same thing. So that tells the doctor that it probably came from the kidney infection. So if we have a patient who has a urine culture with Staph epi in it, and then their blood culture bottle comes up with Staph epi in it, then we would consider that probably a pathogen because it's ironically in the urine too. I mean, it's probably not a contaminant in both places. Okay, other facts, 40% of all Staph aureus isolates are MRSAs. When you have Enterococcus, you always check for VRE. With Staph aureus, you always check for methicillin and vancomycin resistance, and for Enterococcus, you always check for vancomycin resistance. Strep pneumo, 90% are community acquired, meaning the patient comes in with that. Staph epidermidis is the most common cause of prosthetic heart valve infections, but it's also a skin contaminant. Viridans is the most common cause of subacute endocarditis. Okay, the catheter tip. Whenever, I thought I had a picture of a catheter tip. Maybe I don't. With the catheter tip, whenever a portacath or other kind of line is taken out of a patient, especially if they suspect that it's infected with something, then they'll send a piece of it to us to culture. So it will come in a dry, sterile container. Sometimes it has a little bit of blood around it, on it. We need to do it immediately though, because it's in a dry, sterile container. There's nothing in there to keep the organisms alive. And how we do this is we roll the tip on a blood or a chocolate. We roll it around on the plate, and then you put the tip in a broth. Sometimes a gram stain is ordered, and that's real fun to do. It's very hard to culture and gram stain a little plastic catheter tip, because you've got to keep it sterile. So you've got to sterilize some forceps to be able to use it. A catheter tip is considered semi-quantitative. You roll it around on the blood agar, and then the next day you look at it and you count the organisms. If there's more than 15, you consider that significant and you identify the organisms there. Sometimes there'll be maybe 3 or 4 colonies, and they won't even be the same kind, so you know that's a contaminant. Okay, I'm going to stop right there with the first half.